Good afternoon, everyone, and thank you for joining us for Virtual Reality at the Maz, the next edition of our popular virtual expedition series. My name is Carolyn Thompson, and I'm the Director of Philanthropy at the University Hospital Foundation. I would like to start by acknowledging that the University Hospital Foundation is located on Treaty 6 territory, and we respect the histories, languages, and culturals of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continue to enrich our vibrant community. As Emily mentioned, there are technical difficulties with our Zoom's closed captioning today, and therefore closed captioning will not be available during our live presentation. We will send a recording of today's presentation to everybody who accepted our invitation within the next few days, and that recording will have closed caption. Every February, the University Hospital Foundation focuses much of our fundraising efforts on the heart. And that's why we call February Heart Month, proudly presented by Friesen Brothers. Of course, medical teams at the Mazankowski Alberta Heart Institute focus on the heart every day of the year. In fact, every minute of every day, because they have to. Heart disease is the second leading cause of death in Canada and a leading cause of hospitalization. And I'm sure many of you can attest, everyone knows someone with a heart condition. The good news is, thanks to the ongoing generosity of our donors and partners, cardiac specialists at the Maz have more resources to diagnose and combat heart disease than ever before. Today, we're going to learn more about one of those resources, advanced 3D imaging. We are going to learn about what it is, what it does, and the invaluable role it plays in the fight against heart disease. As always, we encourage you to submit any questions you may have during today's presentation through the Q&A button at the bottom of your screen. We will attempt to answer as many of your questions as possible during the Q&A session following the presentation. Now I have a question for you. What brought you here today? Please participate in our live survey by selecting the one answer that best represents why you decided to join us for today's expedition.
The results are starting to come in. We will give everyone about 10 more seconds.
Well, okay, so I can see that we have here with us today many of you who have experienced heart disease. We have caregivers with us today. A special welcome to our students and researchers who are joining us, and our industry and corporate partners as well. And I see many of you have an interest in learning more about cardiac research. So we've got a wide cross section of people who are joining us, and for many different reasons. And regardless of what that reason is, we're so very glad you're here with us. And now, to guide us through the next step of this exciting expedition, I would like to introduce our Chief Culture of Experience Officer and a person who shows her heart every day of the year, Amanda Radakovich. Amanda?
Thank you, Carolyn, and good afternoon, everyone. I don't know about you, but when I hear about 3D, I think about those cool glasses you put on in a movie theater and the very different perspective they add to whatever you're watching. I do not think about 3D as a means to gaining the upper hand on a deadly heart condition or to mapping out life-saving heart injury. But that is exactly what 3D imaging at the Mazankowski Alberta Heart Institute's Servier Virtual Cardiac Centre is used for. Thanks to a generous donation through our strategic partnership program from Servier Canada, the Servier Research Lab gives our cardiac teams the opportunity to study the anatomy of a patient's heart even more closely than if they were holding the heart in their actual hands. Working collaboratively, cardiac surgeons, cardiologists, radiologists, engineers, computing scientists, and mathematicians come together to find the problem and identify the best way through surgery or other treatment to resolve it. And thanks to the advanced 3D printing, doctors can literally hold the replica of the heart in their hands as they determine the best path forward. They also use these models to give their patients a detailed overview of what they'll be doing to fight back against the heart disease that is creating such havoc. Guiding us through the advancements in the cardiac care that this incredible 3D imaging technology has enabled is none other than Director of Servier Virtual Cardiac Centre, Dr. Michelle Noga. Dr. Michelle Noga is a radiologist trained at the University of Alberta and British Columbia's Children's and Women's Hospital. She is currently a professor at the University of Alberta, Department of Radiology and Diagnostic Imaging, a radiologist with medical imaging consultants, and the Mazankowski Alberta Heart Institute Medical Imaging Consultants Research Chair in Cardiac Imaging. Dr. Noga, we are so happy to have you here with us today. The virtual floor is yours.
Thank you for that kind introduction, Amanda. Today, I would like to take you on a virtual tour of 3D in the Servier Virtual Cardiac Centre. First, I would like to acknowledge the generous donation of Servier Canada through the University Hospital Foundation, as mentioned, and also medical imaging consultants for their ongoing funding of my Mazankowski Alberta Heart Institute and my research chair, which provides me with research time. So I'm a pediatric cardiac radiologist, and every day I deal with congenital heart disease, which is disease that people are born with. And in many of these people, the heart is not what we would expect, like the rest of us. So here you see on your right-hand side an MRI of someone's heart. And as my previous professor told me years ago, the heart is a 4-chambered pump. And in this person and most of us it is. So here you see 2 pumping chambers, left and right, and 2 receiving chambers, the left and right atria. However, for some people, that's not the case. This child on the right has 1 little pumping chamber, the left ventricle, and a really big right ventricle, and a common atrium. Looks like 3 chambers. This other child, we can only really see 2 chambers, 1 pumping ventricle and 1 common atrium. And the list goes on of abnormalities that people can have. They can be missing chambers. The chambers can be connected improperly. They can be missing blood vessels, or the blood vessels can be hooked up wrong. So some people really do have unique hearts. And we know that when we're treating congenital heart disease, the best way to make a decision about how to treat is to know everything possible about the patient's condition. In this case, the anatomy and everything that goes with that anatomy functionally. So how do we do that? We do that through imaging, which allows us to see the heart without cutting a patient open. It's things like echocardiography, CT, MRI, catheterization. However, even with very good imaging, some patients just have complicated, confusing anatomy. And it can be difficult. Doctors, nurses, our future surgeons and doctors and patients all can have a hard time understanding what's going on. With these sort of more complex cases, actually, radiologists like myself and cardiologists who do imaging spend hours going over the images. And then we resort to these sort of hand-drawn diagrams to communicate simply with other surgeons and physicians and patients what the anatomy really looks like. Luckily for us, in the 2000s, 3D technologies were introduced into the medical world. So they decreased the drawing. Now we have 3D printing and 3D virtual displays. And here in Edmonton, back in 2004, we began our first 3D prints for heart disease. Here on your left-hand side, this is a set of images from a CAT scan, which just slices through the chest where we've given some dye. And out of those slices, we will shade in the areas of interest, the blood vessels and parts of the heart. And then a 3D printer will take that shading and layer by layer build it into a 3D object that represents the patient's, in this case, blood vessels. So in 2004, we went from hand-drawn diagrams to 3D prints, which was a big change. So the big advantages of 3D printing were that we didn't have to draw. They were based on CAT scans, and these days, now they're based on other things as well, ultrasound, MRI, catheterization. They were accurate, as shown in some of our studies. They are life-size, they can be used for preoperative planning, and they could even be sterilized and taken into the operating room. They also had some significant disadvantages. So this is a mold that we made of the inside of someone's heart. And you can see that the material is very hard plastic looking. It's not very lifelike, actually. And the detail for inside of the heart wasn't good. So this was the state in 2004. So at that time, we turned our attention to something called virtual reality. And that is defined as a simulated experience that employs 3D near-eye displays to give the user an immersive feel of a virtual world. So the key word there is immersive. It's like you're in a room with the heart, and you can slice in, come in and out of it, turn it around and interact with it as though it's a real object. And this picture on your right-hand side is a picture of one of those early virtual displays. And these days, the technology includes many hardwares. The cave that you saw just in that picture, monitors, VR headsets. It's very, very popular now for 3D gaming. And in the Servier Centre, we decided to develop our own local 3D stereoscopic system because there was no system for medical imaging, and we needed to develop our own software as well. So there were some obstacles. One was that the hardware was expensive, especially in the early 2000s. We were able to overcome that with a grant through Servier. And the expertise to make these displays was also scarce because, as I said, you couldn't just go out and buy it. You had to make your own. So we recruited Dr. Punit Kumar from General Electric, who designed the system that we currently used. This led to our opening in October 2013 in a lab space in the Mazankowski Alberta Heart Institute, which became known as the Servier Virtual Cardiac Centre or Servier Lab. And if you come to the Maz, you will be able to see our lab and our equipment. So I'll take you on a brief tour. So this is our front door. And here's some of our equipment. This is our stereo projector, which projects different images to your left and right eyes. And when you put on a pair of goggles, that gives you a perception of depth or 3D. We project onto this big screen, high definition screen, but we also have a second set of small screen that we can also use. So we have different kinds of 3D technology, but these are the two main types that we use, the small screen and the big screen. And we're just going to show you a short video that shows you what some of that looks like. Now, keep in mind that because you're at home and you don't have the hardware, you won't actually be able to see it in 3D, but it hopefully will give you some idea of what things look like in the lab. So here is our big screen with the 3D echocardiogram. The heart's moving, we can turn it, can discuss it, whether it's a student that I was with or a group of physicians or a patient. Here we've added some color to different chambers of the heart in the CAT scan, and we're slicing in and out of it. And we can also add and remove the chambers, you'll see shortly here, just for clarity. So here we're looking at a heart, and I'm adding and removing some of the different structures to help the student understand. This workflow, as I mentioned, is exactly the same whether it's a student or whether it's a surgeon. So after virtual reality, we actually circled back to 3D printing because it's not through 2006 anymore. And the 3D printing has become very common in general use. That's resulted in printers and materials becoming inexpensive, and we can distribute the models very widely. This is particularly useful for teaching. The models are more lifelike because the materials are more lifelike. Surgeons can even cut into them, and their surgical trainees, residents can do practice surgeries. Here's a picture of a 3D printer. This is in the Learning Design Studio in the Faculty of Medicine. It's one that we use. And you can see that it pushes up as it constructs layer by layer. So that results in this picture over here. So that is that's a clear resin that we use. It's flexible and it's great. But as you can see, there's a scaffolding around it. And first we dye it, and that's to enhance the detail, because when it's clear like this, the detail is actually not as visible as it is when it's dyed. After dyeing, we have to remove all that scaffolding. So you see the pliers here, and then that unveils the actual printed, in this case, blood vessels that we wanted to see. So I'm just going to show you a short video of some 3D prints at our lab. And keep in mind that these are just sample of what we print. We've printed hundreds of prints. So here you see red and blue, which can be used for oxygenated and deoxygenated blood. And we also printed different colors so that we can enhance the understanding of the anatomical structures. And you can see even some purple, things like that relate to the physiology related to these abnormal hearts. And here you can see our student is holding it in his hand just as he might in an anatomy lab. So with all these 3D technologies, you might wonder what our applications are. Well, surgical planning would be the first one. So this is our surgical planning workflow. And we operate under the theory that surgeons should be able to see what's happening with their patient and then make a decision and cut, instead of cutting and then seeing the anatomy and then making a plan. So it starts with a surgeon identifying a patient who has complex heart condition where 3D would be helpful. And we go through the shading process as I showed you before. And both 3D echocardiography cardiologist and I do our thing. And that results in a few different sets of 3D. So we've got the CT scan here on the left. We've got the virtual reality beating heart. And here's an example of us using the small screen for that with the labels. And then we also have the 3D prints. Two different kinds of 3D prints. One is what we call the blood pool, a cast of the blood within the heart. And the other is more like the shell of the heart, the muscle and the linings of the blood vessels. And so the cardiologist, myself, a surgeon, and often the patient's cardiologist will often get together in the lab, go through all of this imaging as well as the patient's standard imaging, have a discussion about what the best approach to treatment is, and come up with a plan. And this workflow has been well received. Dr. Alaklabi, who is the head of pediatric cardiac surgery here, has commented on a recent case that 3D images and the models were crucial for their success. In addition, interventional cardiology uses the 3D technologies. Everything these days is not surgery. Many things can be done through a small tube inserted into the patient's groin and used to deliver, that is threaded up into the heart or into the blood vessels and used to perform treatments. So the cardiologist, in this case, identifies a patient who needs this kind of technology. We do the virtual shading for them, and sometimes printing, sometimes both. And after some discussion and consultation, the cardiologist makes a plan and takes the patient to the catheterization lab. Here you see this patient has had a successful stent placed to enlarge the blood vessel to normal size. Dr. Naimi, who uses the 3D technology quite a lot, has commented that these models have made a significant contribution to planning for interventions in patients. Some other applications, well, just because we are in the MAS, we don't always have to just restrict ourselves to things related to the heart. So we do use the technology for other things. This patient had a complex lung condition that needed to be resected, and we used it for that. So other kinds of surgeons will use it in the chest, in the abdomen for tumors. Some surgeons related to blood vessels in the kidneys, orthopedic surgeons for very complex scoliosis planning. We also do 3D research and generate publications from our studies. And something that I haven't highlighted yet is patient and trainee education. So we do take training of medical students, residents, fellows, the future doctors and surgeons of tomorrow very seriously. And the 3D technologies are excellent for training. So I'd like to highlight a couple of educational projects. This first one, actually, they're all headed by Dr. Carolina Escudero, a cardiologist at the U of A here. The first one is looking at 3D models to aid the education of parents who have these small babies who are affected by severe congenital heart disease. And we would like to see if using 3D models helps parents to understand what's going on in their children better. Another huge project is the 3D Heart Project. And this one is actually a free website that is available to everyone worldwide. It has all kinds of accurate information about congenital heart disease. So, people, when they hear about disease, they might go to the internet, but often the information is not accurate on the internet. Well, this is a fully researched, accurate website. And it has links to YouTube videos using 3D aids to help people understand. And ultimately, anyone in the world who wants to print a sample heart of a particular type of congenital heart disease will be able to download a file from this website and print for themselves. So this includes patients, parents, other surgical centers that might want to use these as aids for education. And we feel this will be a tremendous free resource for the cardiac community. So our short to medium term goals are to bring the 3D workflow into the clinical realm with Alberta Health Services. This would be aided by having more 3D equipment. So like the small 3D monitor that you saw there that we use for echocardiography, we'd have something similar to that in the ORs, in the catheterization labs, in the ICUs and so on. And physicians and surgeons would be able to access those anytime, as well in patient accessible areas so that patients could be able to view their own hearts and so on, and their children's heart. Parents could view their children's hearts to facilitate patient education and explaining of treatments. And we would like to complete the 3D Heart Project as soon as possible. I'd like to introduce you just briefly to our team because it's a large one. The medical imaging consultants, radiologists, especially my colleagues, the pediatric radiologists who do much of the clinical work treating patients who are sick and allow me time to work on 3D endeavors. The cardiologists and the surgeons and the allied health professionals who do the imaging and also support our program with frequent requests for 3D help. And the 3D Hearts team, I mentioned Dr. Escudero. Dr. Larson initially started the team and is no longer here. There are designers through the Learning Design Studio, currently Cindy Chen and previously Cody Wesley, and the Servier team who developed our virtual reality systems, especially Dr. Punita Kumar. And I'd also like to thank Jonathan Hampshire, who is the student that you see in the videos. Just a quick video to recap some of the 3D resources that are available in the lab. And I thank you very much for your attention.
Thank you. Thank you so much, Dr. Michelle Noga, for that incredible presentation. Like everyone here, I am looking forward to hearing more about this phenomenal technology during our Q&A session. My name is Prince Osei. I'm a member of the development team here at the University Hospital Foundation, and I'm going to be the moderator for our Q&A session. For our participants today, right at the bottom of your screen, I can even already see some questions coming in. There's a Q&A dialogue box that you can just type in your question. And I have the privilege of reading them out loud to Dr. Noga. And so let's keep the questions going. Dr. Noga, I'm very curious. What is the age group of the patients that you're making these 3D virtual hearts for?
It can be any age of patient. So we have done prints for many babies and children, but these days people with congenital heart disease live well into the adult age group. So we have been printing adults as well. So it's really any age. The determinant is not age as much as it's whether people have disease or anatomy that would be benefited by 3D technology.
How has this 3D imaging improved cardiac care at the Mass?
Well, we feel that when we are able to, with these more complicated patients, when we are able to talk about what's going on in the patient all in the same room, point to the same structure, see it as well as we possibly can, that we make better decisions about what is the next step, whether it's surgery, not surgery, what type of surgery. And ultimately, we feel that translates into hopefully better recovery times after surgery and just better patient outcome.
We've got a question from Shainaya, who is asking, can this help assess valve issues as well, or just problems with the main pumping sessions of the heart?
Yeah. So valve issues are best looked at with 3D echocardiography. And yes, this technology is used to look at the valves.
Okay. And how long does it taking the scan of a person's heart take? And she was wondering if she's understanding us correctly. Is it done through an enhanced MRI scan?
Right. So we can use any kind of 3D imaging to make the 3D products. I mean, the better the 3D imaging, then the better the end result is. But we don't actually, we often acquire this imaging anyway, preoperatively. And really all we're doing is using that imaging to make our 3D as well. So in the case of an echocardiogram, it's probably the 3D sort of sweeps that they do probably add on, an extra 15 minutes or so to an exam, but they would be done anyway. And in an MRI, same thing, it might be a 5-minute extra scan, but usually we would have done it anyway in these cases. So, yeah.
Excellent. So now that we know this, can anyone seeing a doctor or a cardiologist at the Mass request for a 3D imaging?
So yes and no. It's a complicated question. We're always willing to show people what's going on with them. And so if time allows, then certainly, I'm game to show someone what they look like on the inside.
Excellent. Jean is asking, have you sold this technology now that you've developed to other users around the hospital?
We have not sold the technology, no. No, it's not for sale.
Is there capacity for international partnership? This question is coming from Safia. Is there a capacity for international partnership or research to bring this technology to other parts of the world?
Yeah, I think there is capacity to bring it to other parts of the world. I think some things are limited by hardware. So certainly the other places would need to have the appropriate hardware. But yes, we could easily help other centers in other parts of the world to do exactly the same thing. And as you can see from the 3D Hearts website, the printing is portable. So we could just send a file, and if somebody has a printer, it could be printed somewhere else.
And does the 3D imaging take longer to interpret than the traditional 2D technology that we had before?
Yeah, it does. Well, the acquisition is not too bad. Usually it does require some extra processing to make it kind of usable. So yes, there is some extra time involved for sure. Yeah.
Shania is asking again, she's curious whether the hospital will be supporting trying to get these into schools, even at a lower level than post-secondary, to help our younger and future generation gain information and inspiration in the kind of work you and your team are doing.
Not that I know of. I think the hospital, their mandate is not so much education at that level. So I don't think so. I think it would be something where a school would need, or a school board would need to come to us and say, would you like to do a project to get this information into the hands of younger children so they can learn?
I'm seeing a question from Deidre here. Are we able here at the MAS to treat patients from other regions or help support care teams in other regions with this phenomenal technology?
I think I don't know. Healthcare is somewhat regional, I believe. So that is probably something that is outside of my scope. But certainly the congenital heart program does go beyond the scope of Edmonton, right? We service, we do surgeries for Manitoba, Saskatchewan, Alberta, and some parts of BC and the territories. So patients from all of those regions have access, of course. But we have not gone beyond that. And I think it would be related more to the Alberta Health Services scope.
Okay. I do know, as you rightly said, the MAS covers the size of Western Europe. Anyone up north with a congenital heart issue is being flown down here for care and treatment.
Yeah.
Aishana is asking, how feasible is it to have this 3D technology in operation theaters or available during surgery for immediate imaging and feedback?
So, we have wanted to have the technology in the operating theaters. We just haven't been able to. I think we have a lack of hardware and so on, and it requires a little bit more development time, but yes, it is quite feasible. The immediate feedback would require what we would call automation of the 3D processing, so that a patient could have a scan right in the OR, and then the 3D reconstructions and so on would come up right away. So that would require further development, but it's certainly feasible. Yeah.
Okay. Lorraine is asking, can this technology help with assessing if the heart needs to have stents to deal with blocked arteries?
Right. So we don't typically use this technology for assessing if the heart needs a stent for that type of purpose. And the reason I say that is because blocked arteries in the heart are very common, and most people who have that have very sort of what we call typical anatomy, the 4 chambers and all that. So that is an area where actually the 3D doesn't add anything, because your doctor will know exactly which vessel it is and where to put the stent in, and because the anatomy is not varying, everything is in the expected place. The 3D would just probably slow things down.
Dr. Noga, this question is from Tom. He's asking, he had an aortic valve replacement surgery in 2015 and expect another replacement in the future. Would a 3D model be used for this?
So typically, if your valve is going to be replaced, we would not do a 3D model, because it's a simple case of removing the valve and replacing it. If you were an individual who still had your original valve, and there was some thought of fixing the valve rather than replacing it, then that is the time when 3D is used. It's used to see the great detail of the valve and to see what needs to be fixed. And that is a big part of when we use 3D, is to help decide if a valve is fixable and what needs to be done to fix it. But once you get to valve replacement, then you're just going to take the valve out and put a new one in. There won't be any fiddling with the anatomy.
Okay. Celia is also asking, if you feel heavy chest pain, but your oxygen level is over 90, is there still concern to see a specialist?
So if you have chest pain, regardless of what your oxygen level is, then you should see a doctor. There are other causes for chest pain other than just having low oxygen. So yeah, I would recommend seeing a doctor for that.
Okay. This question is from Kathy, and she's asking, does 3D technology help the surgeon to make quicker life-saving decisions?
Currently, the way that we use it, I would say not quicker.
Okay.
I would say more accurate life-saving decisions, but not necessarily quicker, because it does take some time for the processing to happen.
There's one question from an anonymous participant, and he's asking, or he or she's asking, do other cardiac centers in Canada have similar types of equipment, or do we have unique capabilities right here in our city?
Our capabilities the way we have developed it is fairly unique, but I would say that the most similar is at Sick Kids in Toronto. They also do a large variety of 3D technologies, and I would say they're much more invested in the 3D printing side than we are. I think we do a bit more virtual than they do. So, yeah.
If you were to rate the mass around cardiac and research centers around the world, how do we do? How are we doing?
I think we do pretty well. It's hard. I don't know how to. I don't really know how to answer that. I think the MAS is a good cardiac research center. Lots of good research happens here, but certainly there are other good research centers in the world. I mean, it's a big area of study, right?
Okay. Albert is asking, could this technology be transferred for use in other surgeries, that is cancerous cells in delicate regions of the body?
Yes, absolutely. I guess that was what I was alluding to in the non-cardiac application. The medical student that you saw in the videos there, he actually was doing a project where we were looking at resecting tumors from some areas of in the abdomen where they were very close to vital structures, and trying to see if the surgeons would have more confidence when they saw things in 3D. So yes, actually we finished that study. It's being published, and yes, the answer is yes. Yeah.
And Darlene is asking, are you using the technology right now for people who have had or has congenital heart issues only?
Right. So, yeah, we do deal with other conditions as well. It's not exclusively congenital heart. There is what we call acquired heart disease, and sometimes that is, I deal with that as well. And sometimes we use the technology for that as well. It just depends on the situation.
Suresh is asking, I can see that the outside surface getting modeled. How do you get the internal surfaces modeled as well?
So, yeah, that's a little bit trickier process, but yeah, I basically do the same process. I shade in what I would call the myocardium and the outside surfaces. And then, yeah, so it can be done. Is the short answer. It just takes a little bit, it's a little bit more work and takes a little bit more knowledge, I guess, of the anatomy.
How big is your team?
Well, yeah, that last slide, you can see that there were a lot of people. So yeah, it's hard to say. The Servier team of people that do this, probably actually a small number currently, probably maybe about 4 or 5 people who deal with some of this. And then the printer design type people, another few. So in actual fact, maybe about 15, something like that.
Patty is asking, do you use this technology for aortic root aneurysms?
Typically, no. We can, but we usually don't. And again, it's because most people with aortic root aneurysms, their aneurysms are fairly similar to other people's aneurysms. Mm-hmm. And when that's the case, surgeons know what to do with that really well and efficiently. They learn that in their training. So, yeah, we don't usually need it for that purpose.
Dale is asking, how long does a heart scan typically take on average for an adult or a child? And how long does it take to print it?
Right. So it depends on what the type of scan it is. An echocardiogram, probably an hour. An MRI, probably an hour. A CAT scan, maybe 5 minutes. So it depends on the type of scan. Okay. And then the printing process takes hours. So I would say, like, if we want to go from, say, a CAT scan to a print, depending on whether I'm constructing the outside or the inside of the heart or both, that could take me anywhere between an hour and 5 hours. And then we send that to the printer. And the printer usually then, depending on the size of the heart, it's actually more size dependent, can take somewhere between probably 5 and 12 hours to do its printing. It's not a quick process. Yeah.
And I figure it has to be done right.
And it has to be done right, yeah. Which is why the sort of 1 to 5 hours for me, because if it's a real patient, then I'm pretty careful and I check everything over very carefully. Yeah.
Wow. George is asking, can this model reduce operative time?
So we feel that it does, yes. Because I think it's hard to prove in a study. Yeah. But yeah, I think, most surgeons would say that if they kind of have a clear idea of what they need to do, and they know what's going to be there ahead of time, then they could be a little bit more efficient with their time in the operating room.
Douglas is asking, what is the spatial resolution of the system you're using?
Spatial resolution?
Yeah.
Yeah, so it depends on which technology you mean. The virtual reality system is fairly high resolution. It's a 4K monitor, which is old now, I know. And that resolution is probably more limited by our imaging resolution, which is done on something like a 256 by 256 matrix. So probably a little bit less than a millimeter type of resolution.
So Tom has a follow-up question. He says, thank you, Dr. Noga, for your reply to his question. He's wondering if heart surgery will see changes on how it is performed in AHS, meaning he had his chest bones separated. Has a newer, less invasive procedure been adopted?
Currently, no. That is a research project that we've been working on, but it's years from being perfected, which is, some things like surgeries without opening the heart and without opening the vessels and so on. But no, we're not at that point yet.
Okay. And where would you like to see the future of 3D technology? A question from Kathy.
Right. So, I don't think I know what the limit is of 3D technology at this point, because the technology keeps expanding. But I would like to see the 3D technology be used much more in medicine, because it has applications in so many different areas. I do feel that, we are kind of sometimes wasting our 3D imaging, because so much of what we do is actually 3D imaging. So we kind of underuse it to be able to see what's really going on. So yes, I'd like to see it be more widespread. This kind of, actually looking at everything in 3D properly, and especially in education. I think that we could make so much more realistic kind of models and things like that for our trainees to use. So I think the future is really quite unlimited for 3D. I just don't really know exactly what form everything is going to take, because I think it is going to depend on the directions of the technology. Sorry for a general answer, but yeah.
But this is good.
The devil's always in the details.
Yeah. And so someone is very interested in, when you are using this technology, what gives you, Dr. Noga, the most satisfaction? Is it the time saved, the improvement in accuracy?
Right.
Yeah.
Well, what makes me the happiest, to be honest, is when I hear of a good patient outcome. So, I mean, we have, some of the patients that we're using this technology for are patients where they are very sick, and the possible surgeries and options for them, the success is not high. So if that type of patient, if we can make the right decision and they can do well after their operation and go home in a good way, I'm thrilled. None of us like to see people, have trouble after a surgery or, lingering in the hospital because they're not well. So obviously, as a doctor, that, seeing patients get well is my best reward.
Wow. Someone is sharing that his or her dad had a TAVI procedure at the age of 88 with entry through the ribs and not open heart surgery at the Mass. The team of doctors were phenomenal. Is this common?
TAVI is not common, but TAVI is currently being done here at the Mass, yes, and it is excellent. It does tend to be more used in older patients. Yeah.
Maribel is asking, what is the cost to create this? What is the cost? And where is most of the funds coming from?
So the initial startup funds came from Servier Canada. And I would say, well, the grant from Servier initially was $1 million, and most of it went into hardware at the time and also personnel for development. But currently the hardware has actually become cheap. So that, that big screen that you see there, I can't quite remember how much it cost, but I think it was maybe in the order of $100,000 to $200,000 or something like that, and similar for the projector. And now the smaller screens, like I showed you on that table, I think we can get that where you don't even need glasses for maybe $5,000. Like, the technology has really become a lot cheaper.
Wow.
So yeah, initial startup, because it was unusual and rare and whatever, was extremely expensive, but now the hardware is so much cheaper that we can really do a lot more. Yeah, I mean, adapting to new uses and making things more accurate and more applicable and faster will always be a personnel cost. But, yeah.
Stephen is asking, and I think there's a question on everyone's mind.
Yes.
Will this technology lead or help lead to robotic cardiac surgeries?
So interesting. Yeah, I think yes. The robotic is in the same category with some of the 3D technologies. It's a different technology officially, but it is actually an area that our lab has ventured into. We actually do have another project on the go with robotic arm scanning for 3D echocardiography. So yes, we're into the robotic side, and as far as robotic surgery, that is another leap from that. So I think it will ultimately get there, but there's going to have to be a lot of steps in between, because anytime you're actually doing something on a real patient, you have to go through a lot of levels of testing before you get there. So I think it's still probably a good 10 or 15 years away, but I think that is one of the possibilities. Yeah.
Kathy wants to commend you and your team for the phenomenal work and research that is being done here at the Mass. Yeah. There's a question about how can I support more of the advanced technology at the Mass? For our participants today, you can support cardiac research and innovation like this by donating to the University Hospital Foundation. You can visit our Heart Month at heartmonth.ca, heartmonth.ca, to support this incredible work and research. This is all the time we have for the questions for today. Dr. Noga, this has been phenomenal. Thank you. Thank you for bringing us into your lab and into your world of 3D advanced imaging, into this virtual reality. I will now turn back to my colleague, Caroline, to take over.
All righty. Well, thank you, Prince. And wow, what a journey we've been on today. Thank you, everybody, for your active participation. There was some wonderful compliments that came through on the Q&A. We saw them and we thank you. There was also a request for the website that Dr. Noga referenced that had the free 3D downloads. And so I just wanted to let you know that that website is 3dheartproject.com. So again, that's 3dheartproject.com. And that is the number 3, the letter D, heartproject.com. We also had some questions come in about when is our next virtual expedition? Well, thank you for your interest. We are working hard on the rest of the schedule for 2023, and you will see that on our website. And as well, if you received an invitation for the registration for today's virtual expedition, you will very likely get an invitation to our next one. Now, on behalf of myself, Amanda, Prince, Emily, and of course the University Hospital Foundation, and of course our very special guest, Dr. Michelle Noga, thank you for your time and your active participation. Within the next few days, we will send you the recording from today's expedition. Please feel free to share that recording with friends and family. Now, if you want to learn more about us, please reach out by email or visit our website at give2uhf.ca. And you can also watch recordings from our past virtual expeditions on the University Hospital Foundation's YouTube channel. So I'll give you a little pro tip. If you Google University Hospital Foundation virtual expeditions, you'll find those recordings there as well. Now, don't forget that February is Heart Month at the University Hospital Foundation, and we are raising funds to support advanced cardiac care at the MAS. Visit heartmonth.ca to learn more about how you can help us change lives during Heart Month, which is proudly presented by Friesen Brothers. As we mentioned earlier, ongoing community support is vital to ensuring that the work of innovators like Dr. Noga can continue to make breakthroughs, advance patient care, and improve health in the communities we serve and around the world. Thank you so much for joining us today. And to conclude, we will leave you with a short video entitled Ignite 2030. Thank you, everybody, and have a lovely evening. Good night.